Hi, I'm Dr. Kilpatrick. As endocrinologists, we are often asked to evaluate patients with severe hypokalemia. Today, we'll review a not uncommon cause, Gitelman syndrome, and discuss how clinical and genetic testing can confirm the diagnosis.
When an adult patient presents with unexplained hypokalemic metabolic alkalosis alongside a normal or low blood pressure, the clinical picture initially seems contradictory. The kidneys are simultaneously losing acid and potassium, while the systemic volume remains curiously contracted. In adult populations, the immediate statistical assumption is that this highly specific electrolyte profile is acquired. Clinicians are trained to suspect behavioral factors first, predominantly surreptitious vomiting or the chronic abuse of prescription diuretics and laxatives. Those external variables must be definitively ruled out before you can move forward. Only when you isolate the kidney from behavioral interference can you begin investigating an inherited salt-wasting tubulopathy. Among those inherited disorders, Gitelman syndrome is the primary Mendelian culprit. And unlike severe congenital tubulopathies that present in the neonatal intensive care unit, Gitelman frequently avoids detection entirely until late adolescence or adulthood. Diagnosing this rare syndrome requires bypassing behavioral mimics to identify a specific multi-ion derangement occurring within the distal convoluted tubule. To understand these inherited salt-losing tubulopathies without rote memorization, you can apply a single diagnostic heuristic, the pharmacological mimicry principle. This principle maps genetic defects to the action of common diuretic drugs. For instance, Bartter syndrome disables salt transport in the thick ascending limb. Functionally, this mimics the chronic round-the-clock administration of a loop diuretic. Gitelman syndrome maps to a different segment entirely. It acts as an endogenous, continuous thiazide diuretic. By locking on to the distal convoluted tubule, this continuous thiazide-like state directly disables the transport of sodium and chloride out of the urine and back into the blood. Once you view the disease through this lens of chronic thiazide exposure, predicting the patient's complex biochemical signature becomes a straightforward exercise in deductive logic. The first critical step of the diagnostic funnel is separating the behavioral mimics from an actual genetic tubulopathy. We do this at the bedside using spot urine chloride levels. This graph tracks a patient's spot urine values over time. With chronic surreptitious vomiting, the patient becomes hypovolemic and hypochloremic. As a result, the blue line, urine chloride, remains pinned to the bottom, consistently measuring under 20 milliequivalents per liter, even while the presence of metabolic alkalosis causes the orange urine sodium line to wildly fluctuate. Intermittent diuretic abuse looks completely different. Because a patient takes a pill and the drug eventually wears off, you see wide, unpredictable fluctuations, where both urine sodium and urine chloride spike and crash in chaotic synchronization. Now contrast those patterns with a true salt-wasting tubulopathy, like Gitelman syndrome. Here, the spot urine chloride remains persistently elevated, well above 20 milliequivalents per liter, regardless of the patient's extracellular volume. This steady, elevated state occurs because patients with Gitelman syndrome are entirely unable to concentrate chloride in the distal nephron. They simply excrete whatever amount of sodium and chloride they ingest each day. A persistently high spot urine chloride serves as evidence that the transport mechanism in the kidney is failing, rather than simply reacting to an external stimulus. That localized defect in Gitelman syndrome originates from a loss-of-function mutation in the SLC12A3 gene. This mutation translates to a defective sodium chloride cotransporter, or NCC, on the apical membrane of the distal convoluted tubule, jamming the mechanism that normally reabsorbs salt. Because the tubule continuously fails to reabsorb salt, the patient loses water right along with it. This leads directly to chronic extracellular fluid volume contraction. To defend blood pressure, that volume contraction triggers a massive physiological countermeasure, the aggressive activation of the renin-angiotensin-aldosterone system. This state of secondary hyperaldosteronism forces the downstream collecting duct to rescue as much sodium as possible. But the collecting duct can only reabsorb that sodium at the aggressive expense of secreting potassium and protons into the urine. That specific downstream exchange is the exact mechanism driving the patient's potassium levels down and their blood pH up, generating the hallmark hypokalemic metabolic alkalosis. These dangerous potassium and acid-base derangements represent a physiological compensation for the salt loss occurring further up the nephron. Once you identify tubulopathy, you hit the next diagnostic hurdle. Bartter syndrome type 3 usually presents in early adulthood with the exact same potassium and acid-base derangements as Gitelman syndrome. To separate them, we return to the diuretic mimicry model and look at how these diseases handle the divalent cations, calcium and magnesium. Bartter syndrome acts like a loop diuretic. Loop diuretics inhibit calcium reabsorption, resulting in calcium pouring into the urine, presenting as high normal or elevated urine calcium excretion. Gitelman syndrome acts like a thiazide. Thiazides actively promote calcium retention. Therefore, Gitelman induces the critical distinguishing hallmark of hypocalciuria. The calcium is aggressively reabsorbed. In adult patients, a spot urine calcium to creatinine ratio of less than 70 milligrams per gram provides excellent diagnostic sensitivity for identifying Gitelman syndrome. The second major differentiating ion is magnesium. Gitelman features profound hypomagnesemia, driven by an inappropriately elevated fractional excretion of magnesium into the urine. In fact, severe magnesium depletion is frequently what drives the patient to the clinic in the first place, manifesting physically as fatigue, severe muscle cramps, or episodes of tetany. Furthermore, untreated hypomagnesemia actively worsens renal potassium wasting, which creates a highly destructive loop of continuous electrolyte depletion. If biochemical markers leave room for doubt, the hydrochlorothiazide test serves as a functional backup. Administering a thiazide to a Gitelman patient yields a blunted natriuretic response, simply because their sodium chloride cotransporter is already non-functional. While low potassium and alkalosis signal that a tubulopathy exists, it is the precise, unique pairing of hypocalciuria and hypomagnesemia that specifically isolates Gitelman syndrome from its mimics. While the biochemical triad heavily points to Gitelman syndrome, definitive diagnosis always requires genetic testing to identify biallelic pathogenic variants. Because the disease is autosomal recessive, a patient must inherit a mutation on both alleles of the SLC12A3 gene to manifest the clinical phenotype. However, clinicians relying strictly on lab results frequently encounter the problem of missing heritability. In 15 to 20% of patients presenting with severe, classic clinical phenotypes, standard genetic sequencing will return with only a single identified gene mutation. This diagnostic anomaly occurs because the second mutation is frequently a deep intronic variant or a large genomic rearrangement. Standard sequencing panels scan the coding regions, but often fail to read these deep structural errors. Finding only a single affected allele in a patient with a classic phenotype should immediately raise high suspicion for compound heterozygosity. It should not be immediately dismissed as a clinical misdiagnosis. Genetic testing remains the gold standard, but negative or partial results must always be carefully contextualized against the sheer weight of the patient's biochemical evidence. We can distill this entire physiological process into a clear three-step diagnostic funnel for evaluating an adult with unexplained hypokalemic metabolic alkalosis and normal blood pressure. Step 1. Filter out mimics. Confirm spot urine chloride is above 20 milliequivalents per liter. Step 2. Phenotype the tubulopathy by identifying hypocalciuria and hypomagnesemia. Step 3. Confirm the diagnosis with SLCL12A3 genetic testing, checking for compound heterozygous variants. By treating the nephron as a predictable mechanism governed by specific ion transporters, a confusing array of lab abnormalities transforms into a precise, navigable pathway for identifying rare renal tubulopathies.